Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really awesome guest as part of what we're calling our Health Trust and Local Leadership sub-series of the show, and are going to be virtually heading out to the West Coast today to San Diego to be joined by Dr. Sayone Thihalolipavan, who is the Public Health Officer for the Health and Human Services Agency County of San Diego. Dr. Thihalolipavan is a board-certified physician in public health and preventive medicine with a distinguished public health career that actually started nearby here in New York City's Department of Health and Mental Hygiene as medical director of their tobacco control and chronic disease prevention initiatives. He joined the County of San Diego's Health and Human Services Agency about 10 years ago as the county's deputy public health officer in public health services, and he has worked extensively as a public health medical officer with the Medical Care Services Department. They're leading the Health and Human Services Agency's justice-involved health efforts, which we're getting into. Also, a really interesting countywide initiative known as the Street Medicine Initiative, which helped facilitate and enhance the provision of healthcare services to unsheltered homeless where they live. A very interesting set of initiatives. You also play a very pivotal role in multiple county public health responses, not just COVID, but those focused on Hep A, meningitis, Zika, as well as the opioid epidemic, among others. And he has also worked with the medical examiner, public health services, and others to ultimately conceptualize this idea of overdose fatality reviews. And as he also served as the interim tuberculosis control and refugee health medical director. So been involved in quite a lot, and a lot of exciting topics to get into. He holds a master's in public health from Columbia School of Public Health, his medical degree at NYU, and has been recognized with numerous awards, including as the San Diego County Top Doctors in 2022. A lot to get into today. Honored to have him with us. Dr. Sayone Thihalolipavan, thank you so much for taking the time to come on the show.
Good. Happy New Year, Ira, and honored to be here with you, and really appreciate you having this series.
Yeah, it's really exciting. It's very timely, and so I really look forward to getting into a lot of what you've been doing. And as I mentioned on past shows with folks in the public health sphere, you really do a lot. It's not just one thing, so it's really exciting. Going to be going into all these themes. Before we touch on anything related to that, though, I mean, I would love to start off just by handing things over to you to talk a little bit more about you. You know, I was joking before the show that you are not the first Sri Lankan that moved to Africa. But then came to North America that we had on the show. You're the second. But I would love you to sort of take us through the early days of your journey and a little bit of what got you into medicine in the first place.
And I still want to be connected to the other one, to the first. But the again, appreciate you having me, Ira. My name again is Sayone Thihalolipavan, and really, we are the products of our youth and our upbringing and our exposures from our upbringing, and that has tremendous influence on what makes each and every one of us who we are today, whether it's trauma or protective factors or what we're exposed or not exposed to. And so it probably is worthwhile just digging a little bit into my history. Just that my parents are both Sri Lankan, so I'm 100% Sri Lankan. They were actually doing pretty well, financially, all that stuff. But there was a civil war, as you may know, in Sri Lanka, and so they had the resources, unlike others, to escape and to leave. My father is also a physician. He was a general practitioner, is what they call essentially like a family medicine type of physician.
Mhm.
And so he was working for Nigerian government and working in the rural Nigeria. And that's where I was born. And my brother was born in Sri Lanka, my older brother, but I was born in Nigeria. Didn't really
Okay.
remember too much of it. I was only there for about 4 years. And then Nigeria, as you may know, also became more and more increasingly corrupt. And so, they didn't have a path back to Sri Lanka because of the war. It didn't make sense to go back. So really, they were claiming asylum and went to Canada, which
Uh,
was taking individuals. So, when we talk about immigrants and the impact of immigrants, who are here legally and who are here and helping. I am one of those, right? I'm born
yeah.
abroad, coming in, was in Canada for a while. My dad and my mom were doing odd end jobs. My dad did eventually get a microbiology or lab job, working in a lab and things like that, but they weren't taking positions at that time. So we grew up without much. And that was okay. We really made the most of what we had. We had so much family around there in Toronto area. I was in Montreal and Toronto mostly until about fourth grade. And then my dad at that point had taken the exams again, gotten into the US, gotten into a residency program. Of course, what was taking a lot of folks was pathology, a lot of international medical graduates. And so he got into a program. After a year, he changed to family medicine because he really missed
Hmm.
seeing live people, for better or worse. No judgment on pathologists. And then so we were in Long Island. Then he finished, and then when I was in about eighth grade, we moved to a suburb, Amherst. It's called outside of Buffalo, New York, where he was working in a downtown urban federally qualified health center, or community health center, while we were growing up. And then, that was the first time he was making quote unquote an attending salary. And
Hmm.
otherwise, we had kind of gone through different economic phases, or up the economic ladder growing up. And while doing that, it allowed exposure to different things, to different economic classes, but also, making the most of what we had. And my mom always reiterating to me how important service was, how important it is to still appreciate what we have and to give back however we can. So that really, I think, instilled a drive in me to do more and do a lot of and really go into public service, and
Hmm.
which is what I love doing. And but we are all needed. You are a prime example of someone maybe not necessarily in public service, but who's doing so much for society, Ira. So we all complement each other. And then when I graduated high school, I went to Purdue for undergraduate, was thinking about being a biology professor, and then at some point learned about public health. And what is this thing called public health? And I don't even think those were undergraduate degrees, and now they are. And
Right.
so at that time at least. And then I looked at health departments. I really saw myself being in there. I saw in a lot of the leadership structures and the org charts that physicians are higher up. I was always pressured to be a physician from my parents. And so it kind of helped. And, you can feed two birds with one hand, so to speak. And so I ended up applying to medical school. I was bio and minor in chemistry, so I met a lot of the prerequisites already. And so
Sure.
it was kind of not too much extra work to apply to medical school, and I got into four of them, including one closer to where you are right now. But really wanted to go back into the most urban place I could be, and I loved the idea of NYU and the I was the oddball where I applied, and in my interview I told them, hey, I actually want to do public health. I actually want to, do something different. And I think that resonated and separated me probably from most of the other people who were applying at the time. I had worked in college in things like at homeless shelters and like being like the one person at overnight helping with homeless shelters, of course, doing a lot of various things throughout high school and college to service related things. And so at NYU, I was able to do a lot of community health work. Uh,
Hmm.
and it was appreciated, and it was different than probably many of my classmates and colleagues who've gone on and are doing wonderful things, of course, and some research, some academic, some not, but all doing wonderful things. But it was distinct where I got to work with different groups, whether it's like taxi cab drivers and helping, that certain subpopulation and having health fairs for them, just because, they have a lot of health needs that are often not addressed, and lack of access, and time and money, et cetera. And so that's just one example. But we also did rotation. I did a rotation with the health department. I set up other rotations for other people too, but did a rotation with the health department where I got to do that restaurant inspection. I got to do work on emergency
Yeah.
preparedness for health emergency preparedness, and other things. And so got that broader exposure, and I knew that I wanted to go right into it. So I was really struggling in terms of which residency to match into or to apply to when I was in medical school. And there was, the traditional clinical kind of full clinical residencies like pediatrics, internal medicine, family medicine, et cetera, that I had all considered. But the more and more I thought about it, I thought, hey, there's this residency called a public health preventive medicine residency, and that's kind of like a shortcut or a direct path to what I want to do. Um,
Right.
in hindsight, I probably would do a full clinical residency first, but I did what's called a prelim hospital year, and then I did public health preventive medicine, where I still did focused clinical efforts, whether it's tuberculosis, sexual health, or STD clinics. And then when I actually worked and got the job as the medical director for tobacco control, I helped oversee and saw patients and New York City employees essentially in our smoking cessation clinic. Um, but I think the other thing I just wanted to convey is that, in that journey, there's always multiple ways to get to where you want to get to. And I was so
Yeah.
lucky to have so many wonderful mentors and people along the way. And I don't know if there's a wrong way or right way. I'm obviously very happy where I am, but I am appreciative that in New York, especially at my residency program director, the folks that I worked with in New York were wonderful. A lot of really, really intelligent experts who previously had worked at the CDC, who were EIS, Epidemiological Investigation Service officers in the past, et
Hmm.
cetera. And so we had a lot of subject matter expertise that I largely benefited from. So there's a larger, I think, public service and that New York City Health Department or huge health departments like New York City does for the country
Oh
at
yeah.
large, because they produce a lot of individuals. I know someone in LA who's in charge of their communicable disease, for example, who came from New York. We have someone in our behavioral health services who came from New York and had a lot of training there. And then, of course, you don't have to be from a large health department. We have wonderful experts locally too that I work with every day.
Hmm. Yeah, it's again, I can't reiterate how sort of impressive is the sort of the diversity of what you as a public health thought leader have to be involved in, what you see. And I was just thinking about the your time, before you get to the West Coast and your time with the New York City Department of Health and Mental Hygiene. And as you know, last year we profiled Dr. Vassan, who's previous commissioner. Now he's back in Columbia. But looking at some of your work in that time frame, the non-communicable stuff,
Yeah.
cause of death reporting, working with, looking at pregnant women with the elevated blood levels of lead, part of the nicotine replacement program. We had to really culturally adapt the program to Russian and Chinese speaking folks in New York City. Talk a little bit about, sort of early days of this, because like everything kind of got jumped on your desk, right? I mean, you don't get a choice. Like, I don't want to work with lead or
Yeah.
blood level. You had to work with it all. Talk a little bit about this
Thank
and
you.
that
And
experience.
and I was blessed. I think there is so much opportunity, and public health, just like so many other, sectors, there's always opportunity for improvement. And so I was lucky of doing a residency literally within the health department that I got to choose and identify kind of project opportunities, and they would of course ask us if they had needs, some of my mentors, but I did get to do things like use my biostatistics and epidemiology skills to look through the data on motor vehicle accidents, for example. And I actually identified like an issue with the reporting on cause of death, on in that topic. And then we were able to then take that, of course, with wonderful mentorship, work with the medical examiner's office, educate folks on how to, better code so we have more accurate death data, since that is one of the most reliable data sets that we have. Because
Right.
we do know that unfortunately everyone who dies, we do have a record of that, and so that is reliable. That is 100% of the data. That's not like a study sample where you only get a few folks. You get everyone.
Right.
And you can look at that, and that's really important from a public health perspective. But then, yeah, other topics, whether it's lead poisoning, and just looking at and better understanding. New York City is just a melting pot of so many different cultures. So we have people from certain cultures who may use imported products, or may have been exposed previously to high levels of lead and were impacted, and or may continue, may bring it in, etc. So just due to cultural or other practices. So it's just fascinating, but it's unfortunate that's we have been as a society so reliant on certain chemicals over time, and then we learn about the negative consequences, and then we have to go backwards and adjust our habits and practices and try to remediate things. Lead being, of course, one example of many. And so that was a great opportunity. I got to work on hookah smoking with our environmental health department, and just
Hmm.
like, what is the policies? What are we looking at? I got to work with our substance use group. At the time, and the looking at things like alcohol advertising at the street level for something, for
Hmm.
example, children can see when they're walking down the streets of New York City, because being a pedestrian is just the thing that we all are in New York, unlike here, for example, in San Diego, where I live in the burbs and I'm driving all the time. We were walking around New York a lot, and most people are. And advertisements can be really meaningful and impactful in a negative way. And so looking at, are there any associations or certain communities, do they have more alcohol advertising, things like that.
Yep.
Putting out information for medical providers on newer treatments, or like, how do you do a brief screening, a referral and treatment for alcohol use? How do you use medications like buprenorphine for opioid use disorder, things like that? And at
Right.
that point, that was a newer drug, but that's hopefully a commonly prescribed drug now, especially as we're hopefully on the better end of the opioid epidemic, better side of the hill. But yeah, so many opportunities. And then a lot of it's about being flexible. Initially, I wanted to work on chronic disease. But then there was not enough kind of mentorship capacity in that area, and so I was able to kind of flex and do other things. But
Right.
I'm kind of a generalist. I never get bored because there's so many fascinating things in public health to work on. There's, again, so many opportunities for improvement, so many additional ways we need to be thinking about. Okay, what are the data? What do we need to explore? What do we need to find out? And how do we engage people better to achieve the goals we want to achieve? So always work to do. The other thing I wanted to highlight is that during my residency, I was also able to do things like take call for the communicable disease part of New York City
Right.
Department of Health, and help support those overnight weekend calls coming in. Learn from that. Be part of certain responses. Be part of the public health preparedness response and group. And that was also when I actually got hired after the residency program, where I got to be a branch chief, or one of the many branch chiefs, I'd say, in the medical countermeasures branch. And so we would all rotate during certain activations on how we would support the incident command system from that angle. And
Right.
lots of wonderful opportunities
Right.
to make good happen.
Yeah, you bring up the communicable diseases, and I couldn't help but notice and this was the CDC's Morbidity and Mortality Weekly report back in 2016, where you're involved with Jay Varman, a bunch of other important folks, some CDC and New York City Health and Hygiene, thinking about Ebola and travelers and arriving. And obviously, in New York, you had multiple airports and heading in and out, right? And I would love you to just talk a little bit about this period, because we forget, we have a kind of a malaise, let's say, in
Yes.
remembering when stuff like this happens. We remember COVID, of course, but a lot of other stuff in terms of these bugs come in and out. Some of them are like Ebola are no joke. And in all the discussion nowadays of why we need, the Epidemic Intelligence Service, or
Right.
why we need to
Exactly.
monitor what's going on in Liberia or Mali or wherever. There's
Right.
a reason sort of the international angle is important to keep us safe here,
Right.
where we are separated. We're not really that separated. Talk a little about 2016 and some
You're
of your
100%
experience.
right. Thank you, Ira. Yeah, no, I mean, the best defense is a good offense, right? And so the work that we are able to do internationally to better understand and contain other diseases, outbreaks, epidemics, et cetera, ultimately and selfishly do help us in America. And so that is, when we think about public health, viruses, bacteria, fungus, these things don't have borders and they don't know borders. Those are human man-made artificial things. So to your point, yeah, these are easily, communicable and can be transmissible across borders, across oceans, et cetera. So Ebola is a good example. Like we were more prepared, and some could argue we were maybe in a better position then than we are now, for the reasons that you stated. So we thankfully, like I said, we had so many subject matter experts in New York. We worked with the CDC closely. They have a quarantine, station at the airports, et cetera, and so quarantine division, I should say, division of migration and quarantine, and then of course the health department. And so there were subject matter experts who were really SMEs in that area in this particular disease. My kind of maybe minor contribution to it was just supporting and being a branch chief, like I said, on the medical countermeasures part. We did a lot of. I remember we were working like I want to. It felt to me like 100 hours a week, but maybe it wasn't that many. But around the clock, so to speak, and in that activation, I know one of the interesting things I got to do was I got to visit two of the people exposed daily for their 21 days while we were observing them, just in case they developed symptoms. Thankfully, they did not. But that things like that are critical. But you need frontline folks to do that. But again, I was just one piece of, and really we had like Jay Varma and many others who provided such expertise and leadership during those times. And this is what you're referencing, Ira, is that the American public often doesn't understand the value of quick action, of competent action, and of prevention, right? Whether it's communicable or chronic disease, prevention is really hard to sell how valuable prevention is. But Ebola could have been way worse. We had that one case. I think there was one in Texas, if I remember correctly. But then really, I mean, it could have been a lot worse. And many things we deal with day in and day out could be a lot worse. We are seeing that play out today with measles, which is worse, unfortunately, but can be preventable. But
Yeah.
unfortunately, there have been outbreaks across the country. Wouldn't be surprised if there was some in California, but recently at least California has been spared. But right, and there are some of that is impacted, unfortunately, by the rhetoric and the dialogue and the confusion around vaccines today, and not abiding or following the evidence as much as we should be. And we will be losing our measles elimination status pretty soon unless something drastically changes.
Yeah. Yeah, it's an odd situation we find ourselves in 2026, and we'll come
Right.
back in a little bit to sort of how major public thought leader, health thought leaders like yourself are helping to rebuild that trust as we move ahead. But let's talk first a little bit about your current purview, because San Diego County, and just especially for maybe those international listeners that we have here, much more than San Diego. You have a population of over 3.3 million folks there. So in San Diego itself, plus Carlsbad, Encinitas, Chula Vista, Oceanside, a bunch of other cities that you're responsible here. Just talk about the current position, if you would, that you are responsible for, a little bit of your purview, and then we'll drill down on several of the projects that you've been involved in the last year or
Sure.
so.
Yeah, and it's fascinating. I've always been involved in local public health, and the Ebola is a good example of where local has to work with state and federal and international even agencies. But so I'm the health officer or public health officer of San Diego County. San Diego County is the fifth largest county by population in the country, in the
Yeah.
US. And so, like you mentioned, 3.3 million ish. And then we have 18 different cities, city of San Diego being by far the largest, but many others. And then we have some smaller cities. And then we have a large, what's called unincorporated, area, which is not the city, but essentially we, the county, are the city manager, for the unincorporated area, which is vast and really mostly, for the most part, rural, but not all. And so we are the one health department. We are also very unique. I know every county, I'm sure, is unique, but we are unique in that we have the biggest border crossing at the port of San Ysidro right here. And we have a huge military presence and a Navy presence in San
Yep.
County. We have folks across the political ideology spectrum. We have folks who live very urban and coastal areas to very rural areas. We have the most amount of Native American or First Nation tribes in any county in the country. I think we have 18, but please don't, I might be off on that. We have the most amount of small farms, things like that. And so there's a lot of things that make us unique. Also, from a county and governance perspective, the county, unlike many other counties in California, for example, we don't have our own county general acute care hospital. So since we do not have our own general acute care hospital, we have to partner with a lot of the hospitals, and we have to work with them, which forces us in a good way to collaborate. We do not run our own federally qualified health centers or community health centers. So we partner a lot also with our community health clinics. And so our healthcare providers are critical partner and a wonderful partners, but that forces us to be very collaborative because it's not like we are delivering a lot of that direct service. We do have some limited slices of direct service and in being in that tuberculosis. We have a clinic that I used to work in up until this job actually. And then sexual health clinic, which I have worked in the past. We have those clinics. We have immunization clinics. Our behavioral health services also has mental health clinics and a psych hospital. But generally speaking, we don't have, a hospital, a general hospital, or clinics. So that makes
Mhm.
us unique, I think, even compared to other California counties.
Mhm.
And then
Yeah, it's
sorry, one
please.
other thing, sorry, within Health and
No.
Human Services Agency and within the county, I'm the health officer, but within Public Health Services, our department, we have a director of public health, and then we have me, the health officer. So we kind of together jointly, where I call us partners in health, not partners in crime, but we jointly run the department. But the director is kind of more the operations overseer and then I'm
Mhm.
the health officer. So I'm involved in all of you know, the health related conversations, which is most of them, so, or many of them.
Absolutely, as you should be.
Yeah.
No, again, it's a very, as you're pointing out, very diverse, not just in terms of its people, but of its different environments and climates and all that. And it's interesting because you mentioned the fact that you are a border county, and interesting. We've profiled over the last couple of years. Actually, a chief medical officer of the United States Customs and Border Protection, but also a lot of military folks in areas like Afghanistan, and more what's sort of defined as the term is austere environments, right? I mean, these very unique environments that medical care is, it may be tricky. Let's put it that way, compared to if you're just in a nice, clean, hygienic office somewhere in San Diego. But I thought a really interesting place to start off, which it sounds like an extremely austere environment, is the street medicine initiative that you've been involved in, because that's, we hear a lot about the homelessness crisis and so forth. Talk a little bit about what is involved in creating, facilitating, and ultimately carrying out something like this, where it's rather austere. It's not it's not
Yeah, of
healthcare in
course.
the traditional way. I think it's a really just interesting example of how you have to adapt to changing environments that may be quite austere, where they
You're
are.
saying it really well, and especially just in general in today's time when certain groups are maybe find it harder to come in, maybe don't trust institutions, are worried about coming in to seek healthcare for other reasons, or just frankly competing interests. More and more, we're thinking of going back to the past of like going to people, right? Remember back in the day when doctors used to do house visits,
Yep.
and so this is maybe not a new concept, but it is relatively new in kind of our modern medical system and how things are reimbursed in our system. So just I believe what is it? It's 2026 now. So this might have been 2024, I believe, or maybe late or early 2025. Sorry, I'm getting my times mixed up. But when at the federal level, there is actually a designated place of service that is outside of a brick and mortar kind of a healthcare facility. So meaning you could provide and actually code from a billing perspective, that you are providing healthcare, in the streets. And so,
Hmm.
so and this is not a new concept. This has been around for decades, around especially people experiencing homelessness, that, this is a very vulnerable population. You have populations and groups that are people experiencing homelessness that literally have all of their belongings in a cart or a bag. And this is your like chronic outside homeless, there's different types of people experiencing homelessness when you talk about couch surfers or other things, but especially for your folks living on the streets, sometimes they don't want to leave their belongings just to even go to a healthcare facility. And we've heard that directly from people who, who used to be homeless, that they weren't even able and they didn't feel comfortable or safe or secure leaving their belongings because that is all that they had. And so to go into a clinic, unless it was such an emergency, then they had to use the emergency department, because nothing else was open, et cetera. And that leads to maybe overutilization or utilization for things that otherwise should have been prevented. So the street medicine concept locally was really fueled by our board of supervisors. Our supervisors passed who's our governing body, they passed a board letter really requiring us to do a street medicine initiative. Like I said in the past, like we don't have clinics, federally qualified health centers or community health centers. So really what our role was, we were the conveners. And so me, my supervisor, our chief medical officer and others, we convened folks, the Medicaid managed care plans, or which is we call Medi-Cal in California, but Medicaid plans, who were advised and directed by the state to really look into street medicine, to consider and giving them an option to pay and subsidize, that type of care because it's not the typical model. It's not as it's designed to not be efficient, right? Because you're not seeing as many people. The throughput is smaller. You have to move resources around. You have to, go in the street, et cetera. So it's a totally different model. So it requires additional thought from a funding and reimbursement perspective. And so the state was really pushing the plans to do that. And then we were pulling them together. We were pulling the providers who were starting street medicine initiatives together, and even others who were just considering it. And then also really pulling together people with lived experience. So there's a group here locally that we tapped into and we paid help us with these meetings, to help design the agenda, run things by them, to help maybe kick off the meetings. And I specifically wanted them to start the meeting because we wanted to center the conversation around that lived experience voice, right? So let's listen to the people who we're trying to serve. And
Hmm.
and I know that seems like a novel concept, but we need to do more of that, and it's not a novel concept, right? Like
Right.
we and so we really center the conversation, and it was really bringing everyone together. Our regional task force on homelessness, which is the group that the federal government funds to work on this, some homeless service providers, some behavioral health service providers, et cetera, to have these types of conversations around, okay, we're all doing different things. There's things that are changing in terms of coding and reimbursement and new options from the state, or maybe reimbursement changing. How do we get on the same page? What are the challenges? What are the day-to-day challenges? What are the systems level challenges? And how do we solution through each of those respectively? How do we share resources? How do the hospitals know who to reach out to when they're discharging someone who's experiencing homelessness? How do they reach out to someone before they even discharge someone? Ideally, when they first get admitted, right? So that they could help them before discharge, and while they're there, to have a trusted entity and group help them, find a place to go after they leave, et cetera. So a lot of this is care coordination and just sharing information, sharing resources, and then while also taking some of that information about the barriers, the larger barriers, and working at that at the systems level, whether it's
Mm-hmm.
locally with our plans or at the state level with the with our state. It's called Department of Healthcare Services. So,
Mm-hmm. Mm-hmm. And somewhat related to this theme, thinking of and then this goes back to a paper that you published a couple of years ago in the International Journal of Drug Policy on drug tracking in the fentanyl era. And again, I'm as we chat, yeah, I'm sitting here on the East Coast in Philly, and we got a major problem here as well as most cities do. And we have profiled some of the tools in terms of the strips that look at fentanyl, and we have this issue with something called xylazine out here, which is this animal tranquilizer that they're mixing in, and then I hear rumor that they're finding carfentanil now, which is even
yep.
more potent. I remember the ads on TV as a kid, talking about this, that, and the other thing with drugs. But I mean,
Yeah.
things are crazy nowadays. And I just, I'd love to hear a little bit about what you're experiencing from a San Diego County perspective. What, is shocking to you? And again, this program in terms of drug checking, which, applies to obviously homelessness, but
Yeah.
also, all citizens. I mean, and so Stephanie Strathy actually was a
Yes.
on
Yeah.
the show as well. So you work with a lot of great people, but yeah, talk about a little bit of what's happening with the opioid epidemic in your neck of the woods, and some of these tools that you're finding are kind of useful in this
And you
regard.
are right that we have a lot of wonderful, really bright people in our backyard. Whether it's biotech, whether it's researchers like Stephanie Strathy, et cetera. So blessed to work with them. But yeah, so the opioid epidemic did not skip San Diego by any means. We
Right.
we have unfortunately been significantly impacted here. When I first came into San Diego in 2015, we were dealing with this more on the prescription side. And so we were doing innovative things like working with our medical examiner and issuing letters where we identified deaths that were kind of where there was also a prescription over the opioid, not necessarily that
Sure.
that's what caused it, but we wanted the
Right.
providers to know, like, hey, like, your patient died of an opioid overdose and you're also prescribing opioids. So just like, hey, be mindful, this is not a punitive thing, but we need you to know. That actually helped drive down a lot of the overprescription, if you will. And of course
Right.
it's a balance. There are people with cancer, et cetera, other things where it is relevant and it is needed. One could argue, right, for palliative care and things like that. So opioids, but we know that due to the marketing and other things, right, that we physicians have played an unfortunate role in exacerbating this epidemic. And now that it's moved beyond that into synthetic opioids, and new things I just heard about. There's metomidine and there's all these other things
Yeah. Yeah.
now too. But it continues to be a challenge. And what we have to look at is we have to look at this kind of in a multifaceted way. There's the folks who are using substances and maybe can use help ASAP, and how do we keep people alive? Then there's in the short term, and that there's things like drug checking. There's things like naloxone, a reversal, agent that can literally save people. It's just like what would do. And think about this like we think about other medical conditions. For diabetes, right? If someone had diabetic ketoacidosis, we would do something to keep them alive ASAP. If someone was having a heart attack, we would, do a balloon and a stent in their heart as soon as possible if that's what they needed at the time. And so we do whatever we can to keep people alive. So understanding and getting that clarity across the whole community, including our public safety partners who we partner closely with, which I'll talk about in a second, about like we need to keep people alive. And then two is then what else can we do? What are there other interventions? And so there are some people who, as long as we're stigmatizing, as long as we're talking to people certain ways, that they will never be open to talking about anything like remotely like treatment or anything like that. And so we have to treat people humanely, just like what we do in the rest of medicine.
Yeah.
And so then people may actually trust you and then be willing to explore things. So we know, and there are data that with some of the medications that work nowadays, like buprenorphine or other things, that people are more medications for opioid use disorder, that people are more likely to actually engage, and in treatment and things like that. And that's because, addiction, I think people often overlook, and it's so easy to overlook that it completely rewires your brain. And so just like tobacco dependency, which is a legal addiction that I used to work on in New York, right? Like that rewires your brain too. It's really hard to quit these things cold turkey. I know some people can, but that doesn't mean that's the best way to do it or that's the easiest, and clearly doesn't work as much as we as a society want it to work. So we have to help people get to a point of clarity, and medications can help with that. Even though some people may think it's another substance that people are using, it helps people think about things clear. It helps people, being able to make other decisions, and not be reliant, and block the euphoric effects of certain drugs, things like that, or
Yeah.
tobacco, with certain meds too, as well, with meds like Chantix, but varenicline. So the we have to also get people to see their providers. We have to build that trust. We have to encourage use of medications for opioid use disorders. We have to do things like drug checking, which are novel, but allowing people who do use to use safely. And so these are harm reduction approaches, right? Like if someone is a diabetic and they're still eating sugar, we're not judging them, and we're not to the point where we're not going to treat them at all, or we're not going to help them, we're not going to save their life. But of course, if there are maybe some lower sugar alternatives or things like that, we would want people to use those. And so,
Yeah.
so things like providing clean needles or safe syringes, drug checking so that they know what they're using. But ultimately, our goal should always still be, to try to get people to move along and consider their circumstances and see if treatment is an option for them, because that would be ideal, of course, but we know that's not always possible. And so while that's always not possible, we have to have these other measures in place to protect people's lives. And then, of course, upstream, we have to do everything we can to prevent people from those addictions in the first place. And that's another whole nother work pill and a whole nother effort, of course, and often different partners in those spaces. And often we're talking about children, whose brains are still developing until like around age 25, 26. But this is why you see in many states, just going back to tobacco, like, so California has a law where tobacco is not legal until you're 21. That is because the brain is still developing. We know that if we can keep people from smoking cigarettes, by the time they're 21, they're less likely, they're like 90% likely to never be a daily smoker. And if you can prevent them from smoking till they're 26, they're like 99% likely to never smoke. So some of the same applies, that thinking applies to other, illicit substances too. And
Yeah.
one of the other things I wanted to say that in San Diego, we're very fortunate, and this also makes us another thing that's unique about us is that we partner really closely with many different entities. So we partner with our medical examiner, we partner with our behavioral health department, we partner with are public safety partners, and that is a non-traditional partner that when I speak to people in other counties and other states, that I don't see as much happening, and even other countries. We had a delegation from Korea a couple weeks ago just learn from us and say how unique that was, and I hear that all the time, and that's just because we have these relationships at the local level, and we've had coalition building that have been
Mm-hmm.
around for decades, whether it's on methamphetamine or prescription drug abuse. And now those efforts have been combined. And I'm actually the co-chair now with our district attorney. So the public health officer and the district attorney co-chairing, right, a substance use and overdose prevention task force that countywide, where we're looking at things, we're looking at the data, and that allows us to talk about what do we need to collectively do, because there is a role for everyone to play, in preventing this. We know that yes, we can't arrest ourselves out of the situation, but we also
Right.
can't treat ourselves out of the situation, because then if everyone had unlimited access, that would also be an issue. So we have
Right.
to do multiple things and partner and synergize wherever possible. And we continue to look at those opportunities. One thing you brought up earlier is one thing maybe worth talking about is overdose fatality reviews is one example.
Okay.
We locally, using opioid settlement funding, we actually were able to start up what's called our overdose surveillance and response teams. And so this is also partner with our EMS group, with our behavioral health, with our ME, and of course, public health leading and co-leading with behavioral health, I would say probably. Is that we're able to look at the data and think about this as we think about other things like communicable disease, for example, for flu as an example. We're able to look, we can track outbreaks, we can track data coming in, and then we can respond to those. If there's an outbreak in a certain area, we'll respond. If we need to do something focal, we will do that. We will. And so we're kind of doing the parallel of that, except with overdoses and probably more acutely speaking because the fentanyl epidemic with opioids. And so we're able to track, are there a lot of overdoses happening in this part of the county? Do we have to do something? Do we have to do, something, take a more surgical approach where we're focusing certain resources there and things like that, and or working with the community partners there, et cetera? Do we have more overdoses in this certain race ethnicity? And the answer is unfortunately yes. Over time, that has changed too. And so, do we have to do different interventions? And so we have this group that's really looking at the data closely. We publish also an annual report on our data, and we continue to track, of course, as well as our medical examiner. And so thankfully, we are seeing numbers go down, but down is still much, much higher where we are today compared to 10 years ago when I came here. So even though we're celebrating, starting to go down, we still have a lot of work to do locally and across the nation, really, on this. And we know there's always going to be new substances. So one of the things that I would argue is that, you know, as we know that the folks who are making these synthetic substances are really smart, are looking for opportunities, are really creative. So there will always be new substances. So taking that
Mm.
assumption in mind, how do we maximize as many protective factors as we need to for our
Right.
societies to be essentially shielded, especially our kids to be as much shielded as much as possible, into so they don't fall into addiction,
Yeah.
and become addicted, which is really easy to do, right? If when you're
Oh,
dealing
yeah.
with, especially these substances, like you just said, the tranquilizer, and the elephant trank, the carfentanil is even more powerful. So as you get more and more powerful substances, it is easier and easier to become addicted.
Yeah.
So our kids are dealing with substances way more powerful than we did when we were kids. So we also can't place judgment because, especially
Right.
knowing that it's even harder now to not get addicted. So we have to deal with all that and
Yeah.
maximize our protective factors
Mhm.
as well as
Yeah,
decrease our risk factors.
yeah, absolutely. And while we're on that theme, I just want to, point out that, and we'll put links to all this within your public safety group is a gun violence reduction project, and it's nice to see that that's falling under your purview as well, because we have done shows on the fact that ages 1 to 19, the leading cause of death now, which is a crazy concept. But the fact that you're moving it under our public health, umbrella and the importance, again, as you were just pointing out, with the new substances coming out, but sort of the reiteration and putting it in every doctor's exam, just to talk to these kids about handguns and just that one other step that could potentially make a difference, I think is a pretty important thing, and it's impressive that it's part of the portfolio there as well.
And I agree that definitely we need to have those conversations, especially in as kids are growing up, and to shield them and protect them as they're being exposed to guns or other things like that, and how to safely handle guns for the folks who have guns legally. And but I do want to say, unfortunately, due to budget reasons, this is a great example, unfortunately, of us being impacted, that our injury prevention program or our violence prevention program has been minimized, and we are still a player, but we unfortunately don't have as big a role locally. Hopefully that changes as budgets change over time, but and we still continue to be partners along with our public safety group, more leading those discussions. But unfortunately, that was a victim, so to speak, of budget issues. But these are public health issues, like you're saying.
Yeah. Yep. Yeah. Um, Coming back to communicable diseases, we chatted about measles and what's happening now the last couple months. I saw, not just the fact that you have this perinatal Hep B prevention program, and obviously a lot of weird stuff there in terms of the Hep B vaccine recommendations. But you also wrote this paper a couple of years ago on what you were seeing in terms of reemerging into pertussis. And obviously we can talk about vaccination and we can talk about all the hesitancy and stuff's happening, but what you seem to be doing is putting another step in place here. With the pertussis work, it was about how can we focus on getting antimicrobial therapy as soon as possible if we have sort of that signal that we're going to have a problem. And then, of course, if people are scared away from what's happening with Hep B vaccine, we got to have some type of intervention there, and specifically when it comes to mother, baby transmission. Could you say a couple words? It's crazy that we're in a time where we have a reemergence of all this stuff, unfortunately. But talk a little bit about that and a little bit of how you think about, the countermeasures that need to be developed in between vaccine hesitancy and these diseases roaring back
Yeah.
throughout our society.
Thank you, Ira. You said something earlier that I think is really appropriate here. You said that you alluded to the fact that we as humans often have short-term memory loss,
Yeah.
right? Or
Yeah.
short-term memory. And so maybe we remember COVID, but not Zika or Ebola, some of these other huge things that have happened, and responses. And so unfortunately, as a society, most people outside of our fields, who are not paying much attention to this stuff, don't remember the impacts of some of these things, and then are surprised and shocked that we aren't playing a bigger role or something like that when these things happen, and when it happens locally. And it's unfortunate that sometimes that's how we work as humans, but so we have to do, I think the appropriate countermeasure is one, I think the biggest countermeasure is building trust with these, with our society, whoever we're trying to serve. For us, it's all San Diegans. I don't care your political beliefs. I don't care if you're rural or urban, or I don't care if you're white or black or gay or straight or whatever. We just want to help you. We just want you to be the
Yeah.
healthiest that you can be. And we want to use the data to help drive those decisions wherever we have reliable, adequate data. Um, and so, and we know from multiple health and trust surveys that medical providers are still the most trusted individuals. The challenge becomes that medical providers have very limited time and increasingly limited time, and then the second group of trusted people is actually friends and family. So depending on, and that's the Edelman 2025 Health and Trust Survey I'm quoting there. But the one of the challenges is that depending on who you're listening to, essentially, you interact more with your friends and family than you typically do with your doctor, right?
Mhm.
And so you may have high trust in your physician, or your nurse or pharmacist, et cetera, but if you're not seeing them that often, your minds are and your opinions are helping to be some are being formulated when you're really dialoguing with your friends and family. And so if your friends and family are hearing you know uh what some people may call misinformation, or things like that, and then that's what's being communicated to you, then it's harder then to get out of that. And so what we have to do as a society is really build that trust so that people know that they can, go to certain places for reliable information. They could have these honest conversations. People should absolutely and always should have, feel comfortable talking to their providers, asking questions. I think there's nothing wrong with a healthy dose of cynicism of, asking, like, why do, as a parent of three girls, and having them getting shots and crying, like, why do I need to do this? Like, is the juice worth the squeeze? And so those are fair questions. People should question things, and feel free to and empowered to question things. But we just want people to understand, where the reliable sources are, and what's data driven, and hear the stories, because we know people don't always listen to data, but people do respond to stories and narrative, and stories based on truth, of course, of some of the impacts, right? Like, we've seen people die in this country in the last year from measles, and that was completely preventable. And just last year, last flu season, not this flu season, but last one, we had 7 kids die from influenza, and that was by far and large preventable, and not all of them had underlying conditions where you would predict that they may be more at higher risk of dying. And this happened during COVID all the time, right? You saw people who were very healthy unfortunately get really ill, and maybe at the extreme level succumb to COVID. And a lot of that was preventable. Not all of it, maybe all the time, but we want people to just know what's actually happening, and how bad this can get, as we kind of retreat to a condition as a society, or a place in society where we don't trust vaccines and modern medicine as much as we used to. So really, I think the biggest countermeasure is building that trust. And how do we do that? How do we engage with people that we don't engage with right now? We often speak in our own echo chambers in public health. We have our CPOs that we typically work with. We work with our healthcare providers. How do we, especially the healthcare providers being that first line and being the most trusted entity, more trusted than local government, for example, how do we make sure that they have the tools they need? How do they have because the patient physician relationship dynamics have fundamentally shifted because of a lot of people's confusion and questions and things like that coming in, their different stances coming in. And I've heard stories from physicians locally that, hey, doc, I love you and I've loved you for decades and you've helped me, but I don't want that vaccine. And you're not going to give it to me. People are coming in with their minds made up, and that is ultimately their choice. But we want to make sure that our provider community is equipped to handle those increasingly challenging conversations, including, for example, obstetrician gynecologists with perinatal Hep B. So we just talked to some of our American College of Obstetrician Gynecologists chapter leaders from California chapter, and we're thinking through how do we make sure that they know how to address this vaccine hesitancy, these questions, etc. And building trust is a process, and we're kind of in a renaissance period right now in public health, where I can't tell you how it's going to look on the other end, but I could tell you that not everyone's going to still agree with us. But we still want them to trust us, right? Trusting is not that everyone has to agree with you, because then you would never trust someone. And then but really, you just want to be able to have adult conversations, essentially, and be able to communicate and respect each other in a way that you trust them, so that and like we know, just going back to street medicine, sometimes it takes several interactions with the same person experiencing homelessness that has had so much trauma or reasons to not trust people, to finally build that rapport and get them to trust you. So and we have groups, and historically we have groups. I could think of our African American San Diegans and or across the country, who've had historical reasons to distrust the medical establishment. And now we're having new distrust amongst other groups, and largely due to the rhetoric that's happening at the federal level. So we just want to follow the data and evidence, and we want to make sure that we have opportunities to trust. And so we are really thinking through, how do we outreach and get to those other communities? We've been doing some thought with your local epidemiologist, with the Public Health Institute, and others, and in terms of how to engage. There's even groups like Braver Angels, who have who health is not their focus, but they're trying to bring people together to have kind of to dialogue, really. And so how do we continue to do that and reach groups that we traditionally don't do, so they could ask us questions? Because based on what people are hearing, people are going to have certain questions and about vaccines, for example. But we don't just need them to trust us on vaccines. We need them to really trust us on everything else that's health
Right.
related.
Yep.
Because while vaccines are critical and important, we know that our top leading cause of death in San Diego, for example, is like cancer, heart disease, um, accidents or injuries, Alzheimer's and strokes and things like that. And some of that is actually impacted by vaccine preventable diseases, which people don't
Right.
understand that link, that we have more heart attacks during, if you have flu, that is a insult
Yep.
or injury to your body, and you're more likely to have other things happen, like heart attacks, or other things. And or pneumonia and other things, right? So we know that that has an impact on some of these outcomes. And even though people have flu, they may die of a heart attack. And we saw it during COVID a lot, where people were dying of other things too. Um, but we also know a lot of that is also more on our behaviors, our lifestyle choices, and our and the policy systems around us that facilitate some of those uh, lifestyle
Mhm.
choices.
Yep. Absolutely. And a lot of these themes that you just brought up, I mean, all sort of coalesce, interestingly, in this really interesting set of programs that you champion based on justice involved health. And here you have sort of a community that substance use, mental health issues, lots of chronic diseases, as well as communicable. Can you just say a few words about what justice? We've never talked about justice involved health efforts,
Yeah.
but if you could just say a few words about what that means precisely, and a little bit of what went into creating this program, which is not just for those incarcerated, but ultimately to help reduce recidivism and so forth.
Course. And, in America, I think a lot of Americans don't realize how much people and their families have been impacted. Most of us know people or have a close family or friend who at least spent one night in jail or prison. But we know that certain communities, and particularly Black and Brown communities, are more impacted. And there are multiple reasons. As a society, America, we have 5% of the world's population, but we incarcerate 20% of the world's population. Our incarcerations are in America. And we this is a tool. The incarceration is a tool that is used disproportionately locally in America than other countries. And other countries, especially as you're looking at your economically kind of developed world, have other support and social services and social supports that help mitigate a lot of the need to use that incarceration tool. Um, there's systematic reasons that certain communities are more likely to be incarcerated over than others. But really, the work and the justice involved health is that, hey, like, okay, as one county enterprise, county government, we're responsible for things like, behavioral health, as at least for severely mentally ill, we're responsible, and then some of that is onto managed care plans. We're responsible for public health. We're responsible for, you know, um, uh, overseeing the county jails, from our sheriff's department. We're responsible for probation and overseeing the youth and the adults who are in probation and the youth detention facilities. And so, but a lot of those clients are shared amongst us as a county enterprise. But how much do we internally work together? And are there opportunities to bridge that gap and then, channel people into services instead of incarceration where it's appropriate, where people are public safety risk, that is, I think most of us would argue then yes, there is a role for incarceration. But sometimes, and really in any county in the country, I would argue, your county jail is often your largest homeless shelter. It's often your largest, behavioral health institution, just because of the people that are there who often would not be there had they had access to other services. And so what can we do to prevent that? What can we do to use that? And so we're trying to channel people into other services, who are at risk of justice involvement so that they can upstream get those services that they need, get their crises helped, get their, instead of police, can we call our mobile crisis line, where we have non-law enforcement come. And then, if it's a safety thing, of course, we want law enforcement there. And law enforcement appreciates that because they don't want, behavioral health is not something they necessarily signed up to do, for example.
Right.
And so, this has been a wonderful partnership. And then also when we literally have people in detention facilities, whether they're youth detention or adult, in the jails, and we don't have control over the prisons, but of course we work with the state and the feds on other things too. But just at the county level, right, those are opportunities, because they are, unfortunately, they're in detention or incarcerated, but those are opportunities to engage with folks to take that restorative, rehabilitative approach, and then set people up for success when they leave. Make sure they have access to things like housing, healthcare, and then also the tools so that they can make other choices and don't get back and, so it's not a revolving door and back into incarceration. I will say though, as a country, a lot of people are not aware. And if you look up collateral consequences, I believe there's like this inventory, and I can share the link later.
Sure.
There are so many different regulations around folks, especially felons, that they can't have access and do. And I think these were probably done with good intention, but like I think there's like 12 to 1600 in California alone, and I believe there's like several tens of thousands when you look at all across the country. And so these are, these are folks who a judge has agreed that they're okay, that they've served their time, that they're okay to go back to society. And then when we talk about people having a second chance, the cards are really stacked against them because, they can't get a loan to start a small business. They can't vote in certain places. They can't get a fish and wildlife, license, things like that. They can't, they have less access to certain things that then makes it easier, unfortunately, to continue, whatever got them into incarceration in the first place. I would argue that there are some policy things that we have to look at in society and see, like, okay, do we really need that many regulations for felons? Because maybe it is appropriate for, certain ones of them, but are they all needed? And
Yeah.
are we setting them up for success or failure, essentially? And those are some things at the systems level. But what we are trying to do more in terms of like, access to housing, access to services, et cetera, we are piloting a program where we have people with lived justice involvement experience as kind of support or community health workers do in-reach into our local jails and then work with people before release and actually make sure they have whatever they have, be as a coach, be a mentor to them after release, and then connect them to a community clinic and things like that, and look at their broad needs and not just physical health but mental health and social drivers of health, things like
Yeah.
that. So, and then California, we are one of the states that has implemented what's called 90-day pre-release, and that's a use of Medicaid that is in detention facilities. So Ira, you may know this, but since the conception of Medicaid in 1965, or inception, sorry, of Medicaid in 1965, there's always been what's called a Medicaid inmate exclusion policy. And this is the first time that, there was access granted from the federal administration a couple of years ago to
Hmm.
allow, using Medicaid dollars to allow Medicaid in detention facilities up to 90 days pre-release to help with health needs, and then also help with those reentry needs, like connecting them, forming a reentry care plan, connecting them to the providers on the outside so that it's a smoother transition so people get those services met and they're less likely to, more likely to succeed, I'll say,
Yeah.
things like that. So, we have to look upstream, and those are systems changes that are beautiful. And I hope that we can hopefully demonstrate a positive ROI with that and continue that.
Yeah, absolutely. Absolutely. And thinking again about systems and sort of these big picture social issues, I couldn't help but notice this was a couple months ago, Sam, where it was a symposium that you were a featured speaker on. It was entitled "Future of Healthcare for an Aging Population,"
Yeah.
and aging is such an interesting topic, but we've focus a lot on the show from sort of various angles. And we profile a lot of the high tech stuff going on in biotech with regard to longevity and age tech and all that. At the same time, as you're pointing out earlier, I mean, the things that still kill us, number one and two are heart disease and cancer, and a lot of low hanging fruit from the public health perspective that we might not always think about. But I would just love to, and I realize I'm taking a lot more of your time, but
No,
if
you're
you could just
good.
say
Thank you.
say a couple words
Yeah.
here on how you look at healthy aging, healthy population aging in your current role, and a little bit of what's going on to create what I would call sort of this decade of healthy aging per the WHO and all that in your county.
Thank you. Yeah, this is such a critical topic because we're not getting any younger, and as a
Yeah.
society has is really clear, we have to increasingly pay attention to our aging population. There's things like social isolation, which
Yep.
are impact our physical and mental health, but then there's also our infrastructure. Are we age friendly in our approaches? Think of things like we do ADA, American Disabilities Act, forced really us to be kind of disability friendly in a lot of ways, right? To create ramps, to things like that, make it accessible for people with disabilities, make certain things accessible. We essentially have to continue, and there's a lot of work being done on this. So continue and enhance the work that we are doing as a society to be age friendly. Another parallel is we have baby friendly hospitals, for example, that are set up and have to go through certain standards to be qualified as baby friendly. If they're promoting things like breastfeeding and things like that, and evidence-based practices. And so on the parallel path on with our aging population, there are things we could do. There's things called the four M's, and how we can conceptually think through how do we, from medical and health and public health perspective, make our society more um, kind of like easier for our aging population to access care. And it may be harder, with some of the solutions that are working with some of our younger population, where there's tech solutions or something. We may have to think through things differently for our aging population. We may not. There's people of all different. There's young people who are not tech savvy, and there's old people who are tech savvy. So we always have people across the spectrum, but we have to look at the needs and then think through, do we have enough, is our infrastructure, is our approach adequate for folks who are aging? I will say for our Medi-Cal population, one example recently that I've seen that's a systems change is we have some supports available that people may not know that some of their plans offer, but they'll pay for them to do things like home modifications, like putting that thing in the shower so that you can hold on it and you don't, if you're slipping or something like that, building ramps in your house if you need it for a wheelchair or something else like that. There are things we could do to modify and mitigate. And ideally, we want people to age in place, because when
Yeah.
you age in place, you keep your social circle, you keep your,
Yep.
you're not depressed because you're all of a sudden in a new environment. there are, of course, benefits to being in certain areas, and some people need that assisted living. They need higher levels of care, and that is appropriate. But wherever we can, we know that keeping people in their setting is least disruptive to them and most beneficial, generally speaking, when possible and when clinically appropriate. And so as much as we can do to mitigate and enhance our local environments, but also we have to think about our medical system and beyond healthcare, frankly, right? Looking at society, so and how do we help people who are aging? How do we make grocery stores more accessible? And you saw during COVID, like some stores are open earlier for older adults because they were more at
Right.
risk. We should be thinking like those types of solutions in general, not just when we have a pandemic, right?
Right.
And how do we make things easier for our older adults?
Yeah, absolutely. Absolutely. Extremely important points. Um, Sam, I could go on for hours talking about these different topics with you, and we'll probably have to do a couple follow-up shows. But any other major things you want to mention while we have you today as we head into 2026? I mean, we will put the link obviously to the
Yeah.
website until everyone can see the vast extent of the programs that you're involved in beyond what we're talking about today. But anything coming up that we should know about that's public facing as we head a little bit into the first couple of months of the year? And then anything I missed that you want to mention while we have you there, please.
Thank you, Ira. Again, this is a wonderful opportunity. I just say there's two other things I would love to highlight.
Sure.
And is in addition to the trust, the partnerships, et cetera, there are opportunities, even though we're dealing with changes in terms of new guidelines, for example, for vaccines that just came out
Yeah.
this week or last week or whatever, that are without any new evidence. There are things that are happening that could be opportunities. And so one example of that is, the Make America Healthy Again movement. Are all of the things that are being touted evidence-based? No, like
Mm.
community water fluoridation and getting rid of fluoridation. I mean, that is a tried and true public health success story that some jurisdictions like Alberta, Canada actually got rid of fluoride, and now they're putting it back in after seeing the impacts and the huge impacts of not having fluoride. So um, but we have folks like in my field, I'm public health and preventive medicine, but there's lifestyle medicine trained physicians who follow the evidence, who I would love if the federal government right now and brought them into their tent and like had them in those conversations so they can think about how to make America healthy again, but while following the data, while following
Yeah.
the evidence. And of course, having a path always for, how do we, where we don't have data, how do we get those data? And how do we fund, especially as the federal government, the studies and things we need to help us figure out the known unknowns. So that was one thing, is that, the Make America Healthy Again, I do think there's opportunity if the right people are at the table to have constructive dialogue and move America forward. Because as a society, yeah, chronic disease is impacting many of us. But at the same time, just one of the big huge bills last year, sorry, HR1 eliminated a funding source that we called it CalFresh Healthy Living, is from the USDA, but at the federal level, it's called something else. I think it's NEOP, Nutrition Education Obesity Prevention funding. But the or SNAP Ed, maybe SNAP Ed, that's what it is. And so that essentially had us do that policy systems environmental change approach, putting EBT into farmers markets, teaching people older adults Tai Chi, working with our grocery stores to change the way they lay out their display of food and products so that the healthier stuff is more kind of catches people's eyes first and things like
Sure.
that. Like, all these different things at the local and systems policy level. That really made a difference. And that funding has been eliminated, unfortunately. I mean, we have some carrying over till April, but generally speaking, it's been zeroed out, or it's being zeroed out. The other last thing I just wanted to leave is that in I have hope in San Diego, because we as a county, in addition to the substance use overdose prevention task force and that coalition that we built with public safety and public health or health, we have what's called the Live Well San Diego framework. And this is now 15 years old, maybe 16 at this point. And this is one of the things that like made me excited and brought me to San Diego in the first place, and something where we were not as siloed as I felt like in New York, for example, and other places, where we really work across multiple sectors. We have an infrastructure to do that. We have over 660 partners from business, education, CBO, faith-based, all these other sectors that we collaborate with. And so then when something like COVID happened, we had a way to reach out and continue working and focus in on communicating bidirectionally with these multiple sectors. But now that we're out of COVID, we really have to continue to look at, okay, how can we leverage the Live Well San Diego model and the infrastructure, and really, and it's, even though the staff are kind of the backbone of support, this is really a partnership with the community. Is community led in many circumstances. We have community leadership teams, we have 6 different regions that we break the county up into because we're so big, and we have community leadership teams that are co-led by community members, and really the staff doing the backbone support. So we're trying to meet the community where the needs are and where they are, and trying to leverage and partner with the community as much as possible. And so we need to accelerate that, especially as more and more we're seeing there's a distrust in government. And so we're trying to do that. We're trying to bring services to people. We have things like Live Well on Wheels. We have these huge RVs essentially that we've changed out to allow us to go out and enroll people in Medicaid, in the field, so to speak. We can do vaccinations in the field. We can do things like that. And with these types of buses and things, we can do these community events. We can be present. We can be in the community, and again, meet people where the needs are. So I just hope we can continue to do more of that, and continue to think creatively. Last I'll say is, like I said earlier, we're in this interesting period, Renaissance period. I think things will shake out differently than they used to be. We can't do business the old way and expect the same outcomes. So we have to do things differently. So it's exciting but scary. But there are a lot of opportunities, and I think it's really important for people to collaborate and partner and trust each other. So Thank you again, Ira.
Yeah, and again, thinking back to the title of this, well, I'll call us the sub series, in health, trust, and local leadership, and you're clearly, providing evidence of all of that in terms of, working through the issues with public trust in this weird era that we're in, leading locally, and ultimately providing the healthcare community on all these different fronts that you have to think about in public health. But it's all very impressive, and I just again, we will do a follow-up episode to talk about all the things that we didn't touch on today. But really impressive career and work, and I just look forward to continue to follow what you're up to. We will of course put the links in the show notes so people can find you and find these different programs. But again, for everybody out there that's going to be listening to the episode across the various podcast networks, or who will be watching on the YouTube channel, you've been spending time with Dr. Sayone Thihalolipavan, Public Health Officer, Health and Human Service Agency in the County of San Diego. Sayone, I want to thank you for taking the time out of your schedule to come talk to us for a little while and educate us on a lot of what you've been up to. Thank you for everything you do for the health of everyday San Diegans and San Diego County folk, and for our, as we like to say on our show, thanks for helping to create a better tomorrow for them via what you do. Really, really an awesome story, and I look forward to continue to follow you too.
Thank you, Ira. It's totally my honor, and this is helping create a better, environment and life for everyone, because you're helping get the word out around a lot of our work and why we should collaborate with others. Thank you.
Awesome. Great having you on the show.
You too.